we're honoured again to have both Lyndsey Stanley, who's a specialist clinical pharmacist, but also Janet Davies, not from the NMC, who's a specialist nurse. And together they jointly lead a predominantly primary care-based anticoagulation service for Liverpool University Hospital NHS Foundation Trust. They're both non-medical prescribers and they manage a team of 30, which sees in excess of 100,000 patient contacts per year, delivering face-to-face clinics, telephone clinics, home visits. They also do pre and post-op management of anticoagulated patients, as well as being available for patients and healthcare advice. They prescribe and manage patients on VKA, DOACs, low molecular weight heparins, as well as giving vitamin K to over anticoagulated patients. And they've played a fundamental part in designing and developing their service, which saw their patients being moved out of the hospital setting into the community. And for doing that, they've won several awards for collaboration and integration, for quality, Community Service of the Year, and also very proud to have won an Anticoagulation Achievement Award in 2018 for the best ongoing management of thrombosis by a community-based or primary care service. Whew. That's quite an achievement, isn't it? So well done both. I'll hand over to you now for your talk. I'm really looking forward to hearing what you've got to say. And like I said, we'll go through questions at the end. So over to you, girls. Thank you.
Okay, so good afternoon, everybody. Our talk is around the management of anticoagulation in the community, and really focusing on the challenges and achievements. Okay, so the Liverpool and Sefton Anticoagulation Service is not just for warfarin patients in face-to-face clinics, but we also look after patients on DOACs. That's either in clinics, face-to-face, or via telephone clinics. We also offer a face-to-face domiciliary service and a dedicated anticoagulation advice line. And that's for patients, other healthcare professionals, such as GPs, social workers, and really anyone that needs to integrate with the service. We also offer pre and post-operative management to all patients under our care and liaise directly with not only our own acute trust, but also private hospitals and our local heart and chest hospital and other hospitals within the area. So this is the area that we cover. So we have 54 weekly clinics across 34 sites, and the length and breadth is over a 40-mile length, and probably, I don't know how wide, but you can see the span of our clinics there. So we cover Liverpool, Sefton and Southport. The Liverpool area, as you can see, is very, what's the word? Well, I've lost with the words now. That's right, yeah. And Southport is more rural. And we do find difficulties, particularly in the winter months, with the rural areas because of the extremes of weather. We've once had one clinician who's had to be towed out of a lane with a tractor because she got stuck in the middle of winter there. The whole area is a mixture of demographics as well. So we have some very affluent areas in Liverpool and Southport, but also some socially deprived areas which can bring their own challenges. So the service has approximately 9,000 patients on vitamin K antagonists. We have it's already been mentioned, over 120,000 face-to-face patient contacts per year. And we have the advice line, which can take up to 27,000 calls per year. We're very proud of our time in range of 71.4%, and that's 73.1% just in AF, but the 71 is for overall time in range for all conditions. We are a multidisciplinary team made up of specialist pharmacists, clinical nurse specialists, pharmacy technicians, biomedical scientists, and our admin team. And there's just a few of the team together.
We've included this picture here because we really have gone on a journey since we've established the service, and even prior to establishing the service as separate services coming together. There's been multiple paths that we've gone down. We've revisited ideas as we've gone along, always in consultation with the team. And if something hasn't worked, we've not been afraid to take a back step and say this isn't working, and actually take a different approach to it. And we look at some of those challenges that we've come across as part of that journey as we go through the talk. So to give you the background, we initially started off as disparate services. So Janet and myself working for different services in different parts of the healthcare system. So Janet starting off in the acute care setting in 1997, holding very much acute-based anticoagulation service within the acute care setting. And I was very much coming from the community setting, primary care setting in 2004. At that time, we had several services operating across the Liverpool city. So as well as the service that Janet's team were offering in the acute care setting and the service that we were offering in the primary care setting, we also had several GPs across Liverpool who were monitoring their own patients. So we had upwards probably of about 15 separate services across the city. Now this obviously presented problems for the secondary care colleagues when it came to discharge, knowing who was looking after the patient and who to refer the patient back into. And obviously there was a huge potential there for loss to follow-up of patients. In addition to that, further down the line, the acute care setting then started community-based clinics in 2008, therefore introducing further clinics into the community and further potential services that the patient could be under. So in 2014, the local CCG decided to put the service out to tender. And what they wanted to develop was one single service to look after all patients on vitamin K antagonists across the entire city footprint. And both the acute care setting and the primary care community trust at that time collaborated on that tender and was successful in acquiring the tender. We ran that service then as a collaboration for a couple of years, but a couple of years down the line, the community trust disbanded and the team were TUPE'd across to the acute care setting. So we're now actually all employed by Liverpool University Hospitals, the acute care setting. It then went back out to tender after a couple of years, and again, thankfully we were successful at acquiring that tender. And then running alongside that, a tender went out for another CCG service, which covered the Sefton and Southport areas. And we again worked in collaboration as an acute trust this time with another acute care setting. And again, we're successful in acquiring that tender. And then on board came the Sefton and Southport service. The two services worked collaboratively on the service as a whole and tried to very much create a service that was similar across the full footprint, so covering Liverpool all the way up to Southport and Sefton. And subsequent to that, the 2 acute care settings have merged and underwent a trust merge in October 2019. So not only have we gone from 2 services working collaboratively, we're now all under the same acute care trust. That has brought with it a greater movement to a multidisciplinary team. We were already a multidisciplinary team within the Liverpool service prior to the Sefton and Southport service coming on board. So we already had clinical nurse specialists, pharmacists and pharmacy technicians. Prior to the services though being established, it was very much heavily pharmacist based and higher band pharmacist based, and really we've brought in a management structure and a real escalation. So the different professions have someone to go to and they can escalate up concerns, and very much now move towards ensuring that we've got a real skill mix across the team, which has only been further added to by the onset of the Sefton and Southport service as well. The journey as well, we've also over the years developed our domiciliary service. So starting out at the beginning of the journey, it was very much a Venus-based service. So the results would come in to us quite often quite late in the day, 4 or 5 o'clock in the day, and we'd have a couple of hundred patients to dose at that time. So patients would either be getting a phone call late in the day, sometimes they'd already taken their anticoagulant prior to the phone call. Obviously put a lot of pressure on the team at the end of the day in terms of them being able to leave work on time. And some patients were dosed by post, which obviously wasn't ideal. So we decided to move to offering all of our domiciliary patients an equal parity service, whereby they were all seen face to face within their own homes. Now, initially we started off being supported by phlebotomists, and it actually came from the team that a lot of the issues that the other members of the team were picking up on, such as other medication related issues and social issues, were not necessarily being picked up by the phlebotomist that was outside of their role and responsibilities. So after a team discussion, we've come on to review that, which we look at in the next slide. Along the way, we've even tried things like a Skype project with the phlebotomist, so that we could see them when they were in the patient's home and we had that face-to-face contact with them. But again, that's just evolved, and we'll discuss that in the next slide. So the picture here, obviously just to demonstrate, you know, there have been bumps in the road, there's things that we've revisited, there's things that haven't worked, and we've looked at it from a different way. At times it has been an uphill challenge, and we'll just talk about some of those challenges now that we've faced.
Okay, so we've realised over the past few years there has been a decrease in the number of vitamin K antagonist patients, which has led to increasing complexity of the patients that are still under our care. But in saying that, we have had a great number of patients being transferred from the acute setting into the community setting. So all patients who are on vitamin K antagonists with the diagnosis of AF are all seen in the community. That's across Liverpool, Sefton and Southport, which has allowed the acute service to concentrate on developing the pathway of care for patients with VTE, so that they're seen quickly and they go through smoothly into the thrombosis service. So with the increasing complexity, we found that it's not just the face-to-face contacts with the patient, but it's also affecting our advice line as well. So a lot more of the things that we deal with on the message centre in the service, and not just about changing appointments or changes in medication. It's a lot more procedures that require perioperative management. So everything about the VKA patients is over the past few years, even though the numbers have decreased, they have become more complicated. And I think that's also partly because of the age group of the patients, and also those patients who have to stay on warfarin, such as patients with mechanical heart valves or antiphospholipid. Those always present challenges to us. Pre-COVID, we had inappropriate management of over anticoagulation. Only the pharmacists and nurses within the service could administer vitamin K via the PGD. So that meant that some patients, if they were in clinics with our biomedical scientists or pharmacy technicians, would have to maybe go to an A&E service for vitamin K. And that led to its own problems, that they were perhaps just given a prescription for vitamin K to take to a local pharmacist, and the pharmacy may not stock the vitamin K, particularly over a weekend. That may lead to a patient having to go over 72 hours before they receive the vitamin K, which really was inappropriate and putting the patient at risk. Even though our pharmacists and nurses could provide vitamin K with a PGD, it may mean that they go in great distances from a location where they were in a clinic to administer that vitamin K. So it just wasn't working well. And as I mentioned, the techs and biomedical scientists unfortunately couldn't work from the PGD. We were having increasing number of domiciliary visits. This is again with the age group of our patients and the complexity of their conditions. We were also seeing inappropriate switches to treatment, particularly if patients were having admissions, they were being switched to a DOAC, sometimes without any reference to that patient's time in range or the things that could be affecting the time in range. Unfortunately, as a service, we weren't commissioned for DOACs. We were purely commissioned by the CCG for patients on vitamin K antagonists. This was quite frustrating because many of the non-medical prescribers were capable and willing to prescribe DOACs. And it was quite frustrating for myself and Lyndsey because we worked between the community and the acute setting. So in the acute setting, we could prescribe a patient a DOAC, but when we came back to our community setting, we weren't able to do that. So even though we were recognising that the patient was suitable, we were doing the bloods, doing the full assessment, we then had to transfer our own patients back to the secondary, back to the acute setting to be then further assessed, increasing a step in the journey for the patient. So, you know, it just wasn't appropriate that. We had the integration of two services, as Lyndsey previously mentioned. So again, it was different skill sets of our clinicians. And then we had the merge of the two trusts, which again had its own problems, making sure that we were all working to standardise policies, etc. So anything you want to add, Lyndsey?
No, I think it was just recognising really with new professions coming on board, getting to know their skill set and trying to think about some of the problems that they faced, such as the PGD, and getting an understanding of that and thinking about how we could overcome some of those. So we'd like to think, for all the challenges we've been running up this hill, and we'd like to think pre-COVID, we were getting to the top of the hill. And the way that we confronted the challenges. So the decrease in the number of vitamin K antagonist patients, really, we were already trying to work towards moving away from purely being a vitamin K antagonist monitoring service. So we had the desire from the team to get involved with the DOACs, but also other things such as low molecular weight heparin prescribing, and the pre and post operative management, and really using those skills and the expert knowledge of the team. So we feel, you know, over the last few years we have moved away from being purely a vitamin K antagonist monitoring service to now offering a full anticoagulation service. We've mentioned obviously the increased complexity of the team, and we particularly noticed this during the second tender when that went out to the or was won by the acute care setting, and the team were 2P'd over to the acute trust. But you know, the team have rose to the challenge. They've continuously strived to develop their knowledge and skills, and we assist in that by regularly undertaking peer review. So there's not a day goes by really where there's not informal peer review going on. It's quite often the team will phone each other, or you know, a colleague, just for a second opinion on a patient, or if a couple of clinicians are in the office, it's quite a common sight to see them discussing patients, and obviously patients are escalated up to Janet and myself as clinical leads, and to our deputy clinical lead as well. And we do embrace that multidisciplinary team. So when we do have meetings and we have peer review sessions, we do try to ensure that all of the professions are represented at that MDT, so that we can gain opinion from each of the professions and notice that each of them brings a strength and comes at it from a different angle. And I think really that is one of the key strengths of the team. We have, as I mentioned earlier on, we were prior to the service, it was quite heavily orientated to being led by pharmacists. It was a pharmacist-led service, and that has very much changed now and is MDT. But we've also now got that structure in place. So there's a structure of escalation whereby the team always have somebody that they can go up to discuss a patient. So Janet and myself and our deputy lead get a lot of patients sent through to us to review as well. And we do try to manage as many of those as possible in-house, but we are backed up with a consultant hematologist as well, and we can refer directly into the thrombosis clinic within the acute care setting.
So yeah, and we've already mentioned the introduction of the vitamin K PGD. But you know, we sense within the team the frustration from the pharmacy technicians and the biomedical scientists. They were there in the clinic or in the patient's home, recognising that the patient had an elevated INR, aware of the problems that that patient could encounter, and you know, they wanted to be involved in the complete care process of the patient. So we worked together with them to see how we could, you know, solve this problem. So we started to look at the patient-specific direction, and we worked closely with the pharmacists within the acute sector, and we looked across the country to see what other services were doing as well. So we were able to bring together this PSD, and the pharmacy technicians and biomedical scientists embrace that. So that means that they can actually, whilst in clinic or in the patient's home, ring into the office or ring one of our non-medical prescribers, discuss the case with them. And if the non-medical prescriber is in the office, they can look at our other clinical systems, such as EMIS Web, the patient's clinical notes, and discuss with the tech or the BMS the suitability of administering vitamin K. And then the non-medical prescriber can give authorization, and then with the patient, the technician or the BMS can administer the vitamin K, and that has really improved that complete care of the patient. The patient isn't having to go to A&E. No one is having to drive across the service to administer the vitamin K. That's only given if we can see the patient within 72 hours to recheck the INR. So there are cases maybe at the weekend or bank holidays where we still just have to admit the vitamin K, but closely monitor them as soon as we can. And all patients are obviously counselled on the do's and don'ts and all safety aspects.
I think we're very fortunate there as well that we do have access to both secondary care and primary care notes as well, so we can assess the patient holistically and gain a view of what's going on with the patient from both perspectives. But we do very much as well realise that our clinician who's out with the patient is very much the eyes and ears, and obviously if they've got concerns, the patient may look fine on paper, but if they've got concerns about the presentation of the patient, we obviously then escalate that up, and obviously we can again link in with our secondary care colleagues as well. We have obviously noticed an increase in the number of domiciliary visits, now partly due to the increased complexity of patients, the ageing population, but also, as we alluded to earlier on, we're using phlebotomists within the service to carry out our domiciliary visits, and we recognised, and the team recognised, that there were perhaps things that they were not picking up on that we would like to pick up on. A lot of the team, the pharmacy technicians and the pharmacists, came from medicines management background, so it's second nature that when we're in patients' homes that we're picking up on additional issues. So our first try at this was to try Skype, so that the phlebotomist had support when they were in the patients' homes, and hopefully then we would pick up on some additional issues. And we gave that, you know, a good trial. I think we tried it for 6 months upwards, and it still wasn't achieving those outcomes that we wanted from the service. And we then took that back to the team and had a discussion to address their concerns. And they said that they felt they wanted the domiciliary visits to have an equal parity to the face-to-face clinic appointments. We pointed out to the team at this point that would, if we remove the phlebotomist obviously from the service, that would likely have an impact on their workload in terms of the domiciliary visits. But with that in mind, the team felt that that was the appropriate route for us to go down. So what we try to do is we have a real mix of duties, so that clinicians are not just constantly on domiciliary visits. They'll have a mix of being on the message centre, that's answering queries that come in through the advice line, domiciliary visits, working in the DOAC clinic, and obviously face-to-face clinics as well, and annual reviews. So across the week, they'll have that mix of duties. Our admin team also support with the route planning for domiciliary visits. So they'll map out all of the domiciliary visits in a set day, look at the number of clinicians, look at the areas where the clinicians are working if they're assigned to a clinic, and really try to map their DOMs so that they're not travelling extensively, obviously given the large geographical area that we cover. So we very much try to keep our clinicians within a set locality on any given day. In terms of inappropriate switches to treatment, we've had a multifaceted approach to this. So we have an annual review process for all of our patients. And what we've tried to outline in this, we have a template that we send out to the GP, but all patients are reviewed on an individual basis. And we've tried to outline within the annual review letter the things that we're looking at, so that the prescribers are aware. Not only are we looking at time in range in isolation, but we also look at whether the patient's had procedures, whether they've got any compliance issues, and actually consider whether those compliance issues can be addressed by a DOAC, or actually if we're just presenting further risk to the patient, but we won't necessarily know that there are ongoing issues if we're not going in doing the monitoring. Also thinking about social issues, which has really come to the forefront with COVID, that a lot of our patients are isolated and really value that, you know, we may be the only service that's actually going into them and having that check and making sure they're okay. Obviously looking at things like diet, alcohol and other medications as well. We've also approached it by linking in with our pharmacy colleagues in the acute care setting as well. So if we're noticing inappropriate switches coming out of the acute care setting, we've now got a mechanism to report those back up, and they can obviously address them with the individual wards. And then in addition to that, we input into the F1 pharmacist and pre-reg pharmacist training as well. And we give a real overview of all of the anticoagulants and discuss when it is and isn't appropriate to prescribe the various anticoagulants.
And as we previously mentioned, we as a service, we weren't commissioned for patients on DOACs. But because we're part of the acute setting, we link in with the Roald Dahl Centre in the Liverpool University Hospital. And there was a sense that they wanted to further develop their thrombosis service and wanted to move a lot more of the patients away from the hospital setting into the community. So that was moving a lot more of our AF patients from the hospital to the community. So under the basis of the acute trust, using a bulk contract, we could then see patients on DOACs in the community. So that enabled us to establish our telephone clinics and face-to-face DOAC clinics. So our face-to-face clinics are for those referrals that are either coming from primary or secondary care for patients who have yet to be initiated on a DOAC, and they're seen face-to-face and full counselling and full assessment of their needs. And we're privileged in that we don't have to use just one DOAC. We see what fits with the patient's lifestyle diagnosis and then prescribe the dose, the DOAC which is best for that patient. Our telephone service is a virtual service, and that's for patients who have been prescribed a DOAC in the acute setting. They are then referred into our service. We speak to them at 2 weeks post initiation, just to check whether the dose is appropriate, whether they're having any issues, whether their compliance, and basically getting an insight to whether the patient understands the treatment. So you know, it's a really good service which links up the patient with us. So as soon as they feel they're having any issues, they know who to contact. We also then at 8 weeks review the bloods of the patients, the full blood count, the urinase, the renal function, and we pick up there of any issues. If there's no issues at all, then we will discharge the patient back to the GP. We also look at things like the weight of the patient, and particularly the renal function for patients on edoxaban, who if they've got super renal function, obviously we may have to consider switching the DOAC or even doing an anti-10A. So it's a great service that we offer to our patients.
Obviously, the integration of the two services and the merge of two trusts as well has brought additional challenges. So we've extensively worked on standardising all of our SOPs, so all across the service, right the way from the bottom of Liverpool all the way up to Southport, patients then can expect an equal service. And that means that patients therefore can attend the clinic that's most suited to them, regardless of where their GP is. So be it the clinic that's closest to their home or closest to their work, and expect that same level of service. We've already mentioned that we've really tried to utilise the multidisciplinary team and make that one of our strengths, and regularly undergo peer review and shared learning. constantly identifying new opportunities. So, for example, things that we've done for patients of one acute trust, then thinking about actually how do we now ensure that patients who are going into our other acute care setting are having the same level of care, and linking in with both sides of the trust to ensure that that's brought in. And our team meetings, we've ensured that the full team is in attendance, and any working groups that both sides of the services are represented on those working groups, just so we can obviously evaluate the impact that it has across the full service.
So then, if the challenges weren't enough, we then were presented, as everybody else, the COVID pandemic. So the existing challenges didn't go away, but we were faced with making sure and keeping our staff and patients safe, having access to PPE. Unfortunately, as we were part of an acute trust, there was some miscommunication about us requiring PPE. We were going into clinics and into patient and into GPs, where other services from other trusts were going through, and there was conflict of that they may be in PPE. Initially, we didn't have access to PPE, so we had to fight the team's corner with the acute trust, making sure they fully understood the difficulties we were having. Access to clinic rooms was difficult because some clinics that we operated from were closing, the GPs were working remotely. Sometimes the clinic rooms were being redesigned as COVID hubs. So we had that challenge. We had obviously an increased number of patients shielding. So how we were going to look after those patients, what were we going to do? So a case of looking at their treatments, and could we push appointments back? We were unable to access some patients in care homes because care homes were closing the doors. So that was, well, how do we continue to look after these patients, keep them safe, keep them anticoagulated? We were faced with the challenge that some of our own team had to isolate, either through to them having COVID, family members having COVID, so everything that was affecting our patients, such as isolation, was actually affecting the team. We had clinicians working from home, as the trust was encouraging more of the team to work from home where possible. We had issues with staff morale, obviously working in isolation, sort of themselves being affected by COVID. The volume of contacts that we're having with our patients, and sort of natural staff wastage due to things like retirement. We also, during COVID, saw a reduction in procedures as the acute trust was closing its doors to not unnecessary procedures, but procedures that were thought were less urgent.
To tackle the challenges presented by COVID, it really has been a team effort. Testament to the team, they've really pulled together and supported each other. We obviously acquired PPE. We've explained, it was highlighted to the trust that we were seeing patients who were not screened, and potentially asymptomatic patients. So then we acquired PPE. As requested by a lot of the clinic areas and health centres that we were going into, we've had to triage all of our clinic patients prior to them attending appointments, which is, an additional work pressure for the team, but it's ensuring that patients are aware not to attend clinic if they've got themselves symptoms, or if the family members that they live with have got symptoms, and that's been heavily supported by our admin team as well. We've liaised with health centre building managers really to to reassure them about the measures that we've got in place and to ensure that we can have continued access to the clinic rooms. And we've been fortunate that it was just 2 clinics that decided to close the door, but to obviously ensure that we could still meet the patient demand and continue to offer an anticoagulation service and ensure that patients could still be seen safely, we introduced a drive-through service for patients. Thankfully, as it was coming into the winter months, we did get back into the clinic room, so the team were not forced to obviously operate a drive-through clinic through the winter months. But when we did offer the drive-through service, the feedback from the patients was excellent. You know, they really welcomed it, felt safe and didn't have to get out of the car, they could just be dosed in the car. For shielding patients, we assessed those on an individual basis. That resulted in increased domiciliary visits, and for some of our patients who were still reluctant to let us through the door, we did perform doorstep visits, which presents its own challenge given the multitude of weather, even just over the last few days that we've experienced, but obviously thrown into the mix PPE on top of that, with you know, masks that are soaking wet from the rain and the aprons blowing in your face, trying to do a doorstep visit. And the care homes, we've worked with them closely. We had to review patients on an individual basis, and we actually introduced a daily MDT so that we could discuss patients, which our consultant hematologist attended. We have changed treatment where it's been appropriate to do so in line with national guidance, and sometimes that wasn't a permanent change. Patient may have been unsuitable for a DOAC, so are temporarily swapped over to low molecular weight heparin. And we also had to consider the impact that that would have on other colleagues, such as district nurse colleagues as well.
So the requirement of our team members to isolate, we had a daily review of staffing levels to make sure that all clinics and domiciliary visits were covered. We made use of our IT department to enable home working, so that even if our team members didn't have trust laptops, there was a system in place for them to use their own IT systems at home. For clinicians working at home, we had to review the duties to free up clinicians for clinics and domiciliary visits. So it was, even if clinicians thought on a particular day they may be in the office on support and queries, at the last minute we may have to adjust the rota so that those those team members isolating could actually do clinical duties from home, such as providing support and advice. And those other clinicians would then have to go into clinics and domiciliary visits. So basically, we just kept the service running. There wasn't one day where we didn't provide a full service. We were very aware of staff morale as well. Some of our team would be working in isolation for days at a time, maybe because they were working from home or because they were doing complete full days of domiciliary visits. So we started to have one-to-one meetings with individuals. That was either face-to-face where appropriate, or it would be via telephone or Teams Zoom calls. And we tried to pick up on themes that were going on with the whole team and addressing those. We were able to signpost members of the team to the health and wellbeing service within the trust. And for those members of the team that we knew lived alone, they weren't seeing their family members, we really made a particular effort, not just ourselves, but other team members, to link in with them. And the spirit of the team was marvellous. Even when when members of the team were isolating, other members of the team did doorstop food parcels for them. You know, so everyone pulled together. It was a great sense of belonging. And
where we are now, we're very proud of the team. We've carried on throughout the pandemic with 2,000 face-to-face visits a week. We do offer the full anticoagulation service right across the range of anticoagulants, and including pre and post-operative management and dialysis, and supporting our dialysis patients, including out of area where they're seen in satellite clinics. We manage patients who are over anticoagulated in the community setting, reducing the footfall through A&E and ensuring that they're safely managed in an appropriate timescale. Patients are able to attend clinics that's most suited to their life and where they work or where they live. The domiciliary patients have got that equal parity service to what you would expect in a clinic setting. Patients are not having to go into the acute care setting, or certainly not having to go in as regularly, so appointments are more convenient. And as we've mentioned, that the multidisciplinary team we really see as one of our strengths, and we're making sure that we utilise that to its maximum effect, including challenging boundaries where we hit them, such as the PGD issue with regards to our biomedical scientists and pharmacy technicians. And then also we offer an annual review which is individualised to all of our patients. And hopefully, we are seeing the light at the end of the tunnel. We've got a few things in mind for the future.
Yeah, so further expansion of our DOAC service, so that we can do that across the whole breadth of the service. At the moment, it's predominantly within the Liverpool area, but we want to be able to offer that same service in Southport and Sefton. The pre and post operative management across the entire trust. At the moment, the perioperative management is predominantly in Liverpool area, so we want to push that across into Southport and Sefton, again, so that all of our patients have equal access to all of our services. Team working across the entire footprint, further education and development of the whole team, further peer review groups, and further support of our non-medical prescribers, and supporting those who aren't non-medical prescribers to attain that qualification.
Really, we recognise that there will be challenges ahead, even hopefully when we get to this post-COVID period. We've got the new NICE AF guidance that's just come in. So looking at how we adapt and evolve, and really, hopefully it reflects across our journey that we have continuously adapted, evolved and grown the service. And I think that's really the key. And we can definitely see across our journey that we've moved from that vitamin K antagonist monitoring service to the full anticoagulation service. And I think that's really the key to the survival of anticoagulation services, that we continuously adapt, grow, meet the needs of the patients, and think about how we're addressing all of those needs, and if appropriate, bringing them into the community, bringing them to where the patient is, has really worked for our cohort of patients. So apologies, I know we've ran slightly over on that, Sylvia, sorry.
No, that was really, really interesting, and an absolutely phenomenal response to what have been incredibly challenging times. And it sounds like you've had lots of mountains to climb there throughout your journey. And I think for anticoagulation services everywhere, everyone's facing very similar issues, isn't it? So there's a couple of questions that have come through. Are you a 7-day service? And if you're not, would you look towards 7-day service? And what happens at the weekend?
At the moment, we are a Monday to Friday service. We have thought about out of hours services, but at the moment we manage the service well. We've spoken to, we do regular patient satisfaction surveys. So, and we ask them about not just the location of the service, but the accessibility. And that means also the times of them. So we do have clinics that actually open earlier for those patients that work, and we have clinics that open that little bit later for, again, the working population. We've not really had any demand for a Saturday, Sunday service. Going forward, maybe that's something that we may have to look at. We manage our patients who have vitamin K over the weekend by omitting the warfarin, but also make sure they know exactly as and when to link in with the acute sector should they need to. But we've never actually been hit by anyone saying to us, why aren't you available Saturday, Sunday? But if that was a theme that came up regular, then it would be something that we would address.
Okay.
Hematology setting, you know, going into a new hospital as well, that's something that we're looking about in terms of our haematology provision over the weekend, and that may well reactivate, you know, questions, discussions in the future. But we do audit our vitamin K patients as well, just to check that we're getting the outcomes that we desire from the vitamin K, and that it is reversing patients' INRs, but obviously not to the degree where we're over reversing them and leaving them at risk over the weekend. So we regularly audit our vitamin K patients as well.
Okay, lots of love for you both on the chat here. Everyone's loved the presentation. Another question here from Mary Howard. Do you provide a patient self-testing service?
Yes, we do. Unfortunately, we forgot to mention that. Yes, we do. This is we have a number of patients who self-test across the whole of the service, and they have to sign a contract with us, and you know, we contact them if they've missed an appointment to encourage them to do the self-testing. Because we cover such a large area, we cover different CCGs. So in the Southport Sefton area of our service, we are commissioned to provide self-testing monitors for patients who are suitable for self-testing, whereas in Liverpool, patients are expected to buy their own monitors. But in the future, that might change so that as a service, we can assess for self-testing, but also provide the monitors, obviously, plus the education and the training. But yes, we do have quite a large number of patients self-testing.
The contract that Janet mentioned that the patient signs, it's basically to set out obviously our responsibilities, but also the patient's responsibilities, that they will test, they will notify us if there's any problems with the machines, that they will furnish the results to us, and also that they come into the clinic usually at least on an annual basis, and we'll cross-check their machine against ours, because obviously our machines undergo external QC, and it's just about trying to introduce some safety mechanism just to check the patient's own machines working properly. And we also offer training when the patient first acquires the machine as well, just to check they're competent with the use of the machine.
Yeah, brilliant. One last question then, I know we're getting a little bit short on time. So Abdulhamid Hamdi Ramadan again is asking about the DOACs, whether there's any drug or food interactions.
There are drug interactions, or minimal drug interactions with the DOACs. But no real food interactions, you know, and it's quite specific, the drug interactions. It's specific antibiotics, specific antifungals,
Some of your anti-epileptics.
Yeah, but obviously nowhere near the interactions that you do see with warfarin.
Okay, well, I think that's everything. Thank you both so very much for your time, for a wonderful presentation. I look forward to seeing where your future takes your service, and speaking to you again.